because we're putting on more of these high-risk babies. Other things have changed. If you look at agenesis, no diaphragm, about 60 or 70% of those are getting treated with ECMO and no ECMO, or nitric oxide rather, and ECMO not, surprisingly, those are the sickest kids. But the other ones, we don't use it much at all, and that's good because the literature doesn't support its use in most of those. And then if we look at, again, the no diaphragm ones and the ones with diaphragms, the interesting thing is that these high-risk babies, no diaphragm at all. Almost 80% are on oxygen at 30 days, and many of them have reflux. A lot of them have delayed closure of the abdomen. This paper, which we published about a year ago, is why we segued into the one part of the registry, which I don't have all the things to show you, but we can if you'd like. And then we have now a distinct diagram of different defects. And when we get enough patients, which will be in about a year, then we'll publish that as a staging system. Because right now, for us to interpret outcomes from diaphragmatic hernia in broad series it's not useful. Because we know now that there's very high-risk patients and very low-risk patients. And in patients who we can repair the diaphragm primarily, who present relatively late, survival is 95+%. Those are the babies that we were seeing in those early series in the 70s and 80s. Those patients are, one, we don't see them much anymore. And when we do, it's a much simpler repair. Most of the kids I end up operating today are much harder than they were when I was in training, because the defects are bigger, they're on cardiopulmonary bypass. If we also look at the large defect or the agenesis patients, a lot of them, in the early era, we were, even in the 95, there was a lot of people doing this alkalinization, hyperventilation. I'm happy to say that's almost completely disappeared as a management strategy. So we've gotten away from hyperventilation and intentional, not intentional, but unintentional lung injury. And we ventilate the patients a lot different today than we did today. However, this is an important part about CDH. And this is from the group in Rome. But the data are similar. And then if we look at outcomes of diaphragmatic hernia, 78% of their patients were in the average range, but we had somewhat mild delay and somewhat significant delay requiring extra service. There are other papers in the United States that demonstrate the same thing. Language outcome was even more concerning. 40% had mild to significant delays in receptive and expressive skills. There's hearing problems with a number of these kids, and in point of fact, Elise, the young girl I showed you earlier, does have hearing aids as well. Also, we know that 22% of the babies are going home on oxygen, so it's a significant issue with chronic lung disease. And a lot of kids are not eating normally. Reflux is a big problem. The bigger the defect, the more these problems occur. So the large defect patients have all of these problems. Recurrent herniation is very common in the big defect patients as well, especially when we get to the point of no diaphragm. Because if there is no diaphragm, then we have to put some type of prosthetic in. But that's only this big, and then the baby's going to grow. So in the very, very large defect patients, recurrent herniation is almost universal. In fact, it's almost an expected event. However, the group did get together, and this was a multinational thing. We published this in Pediatrics last year. It's available online. It's guidelines and recommendations for post-discharge follow-up. The problem maybe some of you face, when any pediatrician in practice may not see a diaphragmatic hernia, or they may see one. And so they don't have a vast body of experience in terms of what are the things you're supposed to look for, what are the things we're worried about. And so we created a guidelines for follow-up, and this was, I was the author on this, but it was a lot of people involved. And I got input from people in Europe and a lot of people in the States. And this is an AAP-approved guideline. It's detailed, but the key issues are, it's recommendations for what are the things a pediatrician should be looking for if they're taking care of an infant who's had diaphragmatic hernia. So where are we in 2009? Delayed surgery. Surgery in almost every center today is delayed. As I say, in my hands, it's going to be waiting until the baby is on minimum mechanical ventilation. and low pulmonary artery pressures. That may take weeks. We let the carbon dioxide rise. It's called permissive hypercapnia. Before we wanted normal, now we'll accept them twice normal, as long as the patient is doing okay. Because every time I want to bring the carbon dioxide down, I have to turn the ventilator up. So I'd rather keep the ventilator down, the carbon dioxide go up. Our frequency, I didn't go into it in detail for high frequency oscillation. We do use it today, but it's very different. In the early 1980s, we were trying to get the lungs bigger and bigger and expand. That's the strategy we still use today for high frequency. In the non-diaphragmatic hernia kids, it doesn't work that way in these kids, so we have a different strategy. ECMO is largely, as you saw, a stabilizing device as opposed to a lung injury device. The heart is very important, increasingly recognized, so we need to be doing echoes on these babies all the time. There's an interaction between the heart, the right heart as it works against the lungs, and the high pressures in the lungs that we have to have regular involvement with cardiology. We don't use surfactant anymore. People thought it might work, it doesn't. Fetal surgery today is an unproven therapy in the United States. It may or may not have some benefits in a very, very small subset of high-risk patients. Frankly, I hope it does. But today, it's an unproven therapy. We don't use nitric oxide initially. It doesn't work. However, we use it a lot in a very different strategy. And long-term management is clearly an important thing that we're going to have to focus on for patients. As far as the study group, our current plans are to develop a post-treatment staging system that I talked about. We're trying to look at the natural history of hospital-based at least pulmonary hypertension. We are soliciting folks that are interested in participating in the study to look at prenatal predictors and also a postnatal long-term follow-up study. We're going to talk about both of these types of studies have to have informed consent. The registry itself is anonymous. We don't know who's in what patients are in the database, and hence, because it's an anonymous database, we don't have to get informed consent. Much easier to get that, collect those data. However, if we're going to link prenatal ultrasounds to postnatal outcomes in a broad series, we have to have patients' consent. If no other reason, I can't link them to mother and child data otherwise. And the long-term follow-up would obviously also have to be a consent thing. So we've solicited people in the study group now in the last iteration to see if there's interest in doing either one of these trials. Undoubtedly, most centers won't want to participate because it is a lot of work to go through IRB and everything else. But if we can, we're going to try and do something like that. That's all I have. I'm happy to answer any questions.
Does your registry have any data? Our daughter had a repair with abdominal muscle rather than a patch. And my question is, I'm just wondering if you have any data that shows that's improved recurrences of the herniation or...
The biggest individual, unfortunately, because one of the big problems this registry has is hospital-based. Okay. So upon discharge from the hospitals, it has only as long as it goes. The largest series of, most of the patches talk about using part of the front part of the abdominal wall and rotating in. The largest series of those don't give any long-term follow-up. So we don't know. Conceptually, it makes sense because the muscle will grow with the patient. The problem is muscle is not always a great device in and of itself as a barrier because it's weak. And we don't know if sutures pull out, if scar tissue, it's just an unknown.
Well, and it causes her other problems, because she's
not weakened
she's real weak, on that side. So.
Right, and so if you read Eric Scaife in Utah, and then there's another paper who talked about using this in a fair amount of patients, but it's like a lot of things in this field, it's really great until it's not great. And having seen, when you have a problem that has such a high risk of complications and a high death rate, then there's a lot of people looking for answers, and even today. And because of that, you're going to embrace that thing that comes out. Hey, this will work. We embrace hyperventilation.